Hello, everybody. My name is Ram, and let me begin by thanking Dr. Shannon Judd, Dr. Neeta Gautam, and all other organizers of this Stanford Evidence-Based Traditional Asian Medicine Conference. As part of the mental health breakout session, it's my pleasure to talk about the work that we are doing on a comprehensive, individualized, systems-based therapeutic approach for reversing the cognitive decline in individuals with Alzheimer's disease. So, dementia is an umbrella term, and of the many different types of dementia is Alzheimer's disease. Alzheimer's disease represents 70% of dementia cases. Hence, the term dementia is loosely spoken to mean Alzheimer's disease. Alzheimer's disease is a progressive, age-associated neurodegenerative disease. 5 million Americans in the USA alone have Alzheimer's disease. Nearly 360,000 new cases of Alzheimer's disease are diagnosed annually in the USA. These values are not true. They are underrepresented since a lot of people fail to receive diagnosis until it is too late. The disease is characterized by degeneration in the hippocampus, in the cortex, and the subcortical structures as shown in this cartoon. So if you compare the structure on the left side to the structure on the right side, you will notice that there are a lot of structural changes in specific areas of the brain. As the disease progresses, there is a significant structural and functional loss in the brain areas. The most prominent feature of the disease is the memory loss and a decline in other executive functions, which affects day-to-day tasks. Now, 1 in 3 seniors dies with Alzheimer's. 2/3 of Americans with Alzheimer's disease are women. Alzheimer's disease is the 6th leading cause of death in the USA. By 2050, the direct and indirect costs due to Alzheimer's disease will be nearly $1.1 trillion. Now, the symptoms of Alzheimer's disease worsen over time, although the rate at which the disease progresses varies. On an average, a person with Alzheimer's lives anywhere from 8 to 20 years following the diagnosis. The changes in the brain related to Alzheimer's begin several years before any prominent signs of the disease appears. This time period, which can last for years, is referred to as the preclinical Alzheimer's disease or subjective cognitive impairment. It is characterized by increasing forgetfulness and losing a train of thought. Following subjective cognitive impairment, as the condition worsens, the signs become more visible, prominent, and can be divided into 3 stages. Several symptoms overlap between these stages so that it may be very difficult to place a person with Alzheimer's in a specific stage. The early stage of Alzheimer's, or also known as the mild stage, is a stage where a person may function independently. He or she may still drive, they may still go to work, and they may be part of some social activity. Despite this, the person may feel as if he or she is having memory lapses, and they may call it as brain fog. They have difficulty coming up with the right word or name. They may have difficulty remembering names when introduced to new people. They may experience difficulty in performing certain tasks in a social or a work setting. They may forget the material that they just read. They may lose or misplace a valuable object. They may experience increased trouble with planning or organizing. The second stage of the disease is what we call the moderate stage or the middle stage. And this is typically the longest stage and can last for many years. As the disease progresses, the person with Alzheimer's will require a greater level of care. During the middle stage of Alzheimer's, the dementia symptoms are more pronounced. The person may confuse words, they may get frustrated, they may get angry, or they may act in unexpected ways. The damage to the nerve cells in the brain can also make it difficult for a person to express their thoughts or perform routine tasks without assistance. As the person moves from the early to moderate stages, the symptoms become more exaggerated and more pronounced. The late stage of Alzheimer's disease or severe stage is the final stage of the disease where the symptoms are more severe. The individuals lose the ability to respond to their environment. They require around-the-clock assistance with daily personal care. They lose awareness of their recent experiences as well as their surroundings. They also experience changes in physical abilities, including walking, sitting, and eventually swallowing their food. They have difficulty communicating and carrying on a conversation. And they also become vulnerable to infections, especially diseases of the respiratory tract like pneumonia. Now, Alzheimer's disease was first described in 1901. Nearly a century later, we still do not have a cure or a proper treatment for this condition. In the last 35 years, nearly 500 drugs went into clinical trials. The FDA has approved just 2 drugs which are effective only when the patient comes early on with the disease. The very difficult and expensive process of drug discovery has resulted in losses of billions of dollars, prompting the need to revisit the entire process of drug discovery. The very difficult and expensive process of drug discovery is also complicated by the following facts. The exact cause of the disease is still unknown. Only 1 to 5% cases are familial Alzheimer's disease. The rest are of unknown origin. The disease manifests very early on, but the early diagnosis of the disease is not available. The disease exacerbates with other changes. It's a very complex, multifactorial, with too many variables, including genetic, lifestyle, and environmental. There are no perfect models of Alzheimer's disease that exist to recapitulate the disease that is seen in humans. Now, the biggest risk factor for Alzheimer's disease is aging itself, but there are other determinants. One of them is the genetic variant termed apolipoprotein E, which plays a critical role in transporting cholesterol in and out of the central nervous system. ApoE is present as 3 different allelic forms. The most common apolipoprotein E allele type is the ApoE3 with a frequency range of 50 to 90%, while the apolipoprotein E4 is approximately 20%, and apolipoprotein E2 allele is of approximately 5%. The risk for Alzheimer's disease is associated with the apolipoprotein E4 allele. An inheritance of 1 or 2 copies of ApoE4 dramatically increases the late onset Alzheimer's disease risk approximately by 3 to 12-fold. Nearly 70% of Alzheimer's disease patients carry the ApoE4 isoform. Now, despite knowing for 2 decades that the ApoE4 allele is somehow contributory to the Alzheimer's disease process, the precise molecular mechanisms resulting in ApoE4 mediated toxicity still remains unclear. Now, we recently reported that ApoE4 acts as a transcription factor. ApoE4 bound to DNA with high affinity at the low nanomolar ranges, and it bound to promoter regions of nearly 1,700 genes. The genes associated with these promoters provided new insight into the mechanism by which Alzheimer's disease risk is conferred by ApoE4. This is because these genes are associated with trophic support, programmed cell death, microtubule assembly, synaptic function, aging, and insulin resistance. Notice all these processes have been implicated in Alzheimer's disease pathogenesis. Thus, the genetic and biochemical research work from our laboratory and from others have now revealed an extensive network of molecular interactions involved in Alzheimer's disease pathogenesis. This suggests that a network-based therapeutic approach, rather than a single target-based approach, may be feasible and potentially more effective for the treatment of cognitive decline due to Alzheimer's disease. What this means is that we have to come up with smart drugs that can increase, enhance, improve, or optimize all the parameters on the left side of this table. Because in Alzheimer's disease, all these parameters on the left side are subnormal or downregulated. The same smart drugs need to decrease or reduce the parameters on the right side of the table. Because in Alzheimer's disease, all the parameters on the right side are abnormally high. What this means is that we need to have smart drugs that would include either single drugs that modulate multiple pathways or a combination of drugs that affect an entire molecular network in tandem. Now, combinatorial drug therapy is not something new. If you see therapeutic success for chronic illnesses such as cardiovascular disease, cancer, tuberculosis, and HIV, all these have been improved through the use of combination drug therapies. But the question is, until we have a successful drug or drugs, what can we do for those people that have Alzheimer's disease? Now, based on studies from our laboratory and from others, we noticed that the brain has got a close nexus with the gut. In addition, the brain also has a close connection with the oral cavity, the nose, the bone, the skin, the colon, and the gums. Our research work also showed that addressing the digestive system or the gut and the associated organs significantly reverses the memory loss. Since each person exhibits varied symptoms, this approach also becomes highly personalized. So in our health program, all the patients that have received an Alzheimer's disease diagnosis from their neurologist, they come to us and everyone is put on a systems-based multi-component therapeutic approach to reverse or delay Alzheimer's disease. Now, the study that we have been doing for the last 5 years and which is still continuing is a prospective observational cohort study. In this longitudinal study, we follow a cohort of individuals that have been diagnosed with Alzheimer's disease associated memory loss. We have specific inclusion and exclusion criteria. For example, people with the late stage or the severe form of Alzheimer's disease are excluded. Patients with chronic comorbid conditions are also excluded. We closely take into account all the differences in each individual's presentation of certain features of the disease. Patients who are in the program are assigned a specific health coach, and we follow these patients for 6 months, 12 months, 16 months, 18 months, 24 months, in some cases 3 years as well. The outcome measures are quantitative neuropsychological testing using MoCA, the Montreal Cognitive Assessment Test, or MMSE, the Mini Mental State Examination. We also do biochemistry on blood and cerebrospinal fluid. We do brain imaging, MRI, or PET scans for amyloid and glucose utilization. We also do subjective assessment of patients for their own improvements in activities of daily living. All the subjects that have adhered to our program show reversal of the memory based on these behavioral tests, the subjective assessments, biochemical lab tests, and brain imaging studies. Majority of them have been able to get back to work, and several of them who kept up with the program noticed sustained changes. As more people signed up for the program, we started accumulating huge data sets, and these data sets are now helping us to analyze the disease process. In the first analytics, we were able to classify these patients into 3 different Alzheimer's disease subtypes. As shown in the slide, type 1 Alzheimer's disease is mainly described as an inflammatory type of Alzheimer's disease. This is characterized by the presence of pro-inflammatory cytokines, chemokines, acute phase reactants, and other mediators of inflammation in the AD brains. We also notice there is presence of inflammatory microglial cells and activated astroglial cells. All this suggests the involvement of an innate immune system. The pathology of type 1 Alzheimer's disease also shows evidence of systemic inflammation. There is inflammation present in the gut and other regions. All this could come from poor dietary practices, poor oral hygiene practices, or poor lifestyle practices. The type 2 Alzheimer's disease is an atrophic or cold type Alzheimer's disease that is mostly seen in adults that are 60 years and above. It is characterized by withdrawal of trophic support, could be withdrawal of estradiol, progesterone, thyroid, nerve growth factor, or brain-derived neurotrophic factor. We also notice that these people have insulin resistance. They have hypovitaminosis D, hyperhomocystinemia, and in women, hormonal loss associated with early oophorectomy. The third type of Alzheimer's disease is what we call as the infectious type. The type 3 patients represent a group that is totally distinct from type 1 and type 2. The type 3 is characterized by an early symptom or early symptom onset. It's mostly in the younger generation. It's a lack of family history. MRI shows general degeneration in other areas of the brain as well, in addition to the hippocampus. There are other factors that could put these people at risk for type 3, including chronic stress, PTSD, exposure to toxins, metal poisoning, and infections from bacteria, viruses, mold, or fungi. So the classification into these 3 subtypes not only allows us to identify the exact causative factor, it also allows us to use specific therapeutic intervention. Now, if you go back and look at that previous table, and if you're into Ayurveda, it becomes very clear that this Alzheimer's disease can be subtyped into 3 different phenotypes. The type 1, which is inflammatory, is the Pitta type of Alzheimer's disease. The type 2, which is cold or atrophic disease, is now the Vata type Alzheimer's disease. And the type 3, which we call it as infectious, is subgrouped as the creamy type of Alzheimer's disease. So our comprehensive multimodal strategy therapeutic approach involves diet. We tell them to have whole plant-based foods, complex carbohydrates, a lot of vegetables, lean proteins such as legumes, low glycemic grains and fruits. The diet also includes healthy fats, olive oil, coconut oil, ghee. It also includes nuts and seeds. We also put the patients on a gentle ketosis state so that a minimum of 12 to 15 hours fast between dinner and the next day breakfast. We also put them on specific nutritional supplements to correct any deficiencies. It could be zinc deficiency, vitamin D deficiency, B12 deficiency, iron, sodium, potassium, and so on. We teach them cardiovascular strength exercises, balance exercises. They all undergo a 1-hour physical exercise that includes walking, grounding exercises, gardening, swimming, or gym. In the morning, they also have a 1-hour yoga exercise. We also teach them the importance of good quality uninterrupted sleep, at least 7 to 8 hours of sleep. We teach them good sleeping practices to improve sleep quality, to optimize their sleep, and to have a proper sleep environment. We teach them techniques for stress management, meditation, and stillness. We tell them the importance of a regular social engagement. We engage them in cognitively stimulating activities to train the brain in aspects of memory, attention, visual, spatial, and brain flexibility. We also provide them methods to promote neuroplasticity. So we encourage them to take up reading or music. Music could be vocal or instrumental. We also tell them to learn new skills or learn a new language. We also provide them herbs. Herbs are given based on the subtype of the disease, and the rationale for choosing the drugs is for choosing these herbs is very clear, as shown in the slide. Most of these herbs that are mentioned here are Medhya Rasayanas, Medhya meaning brain and Rasayana meaning rejuvenative. So these are rejuvenative herbs for the brain. Mandukaparini Centella asiatica is one of the most important rejuvenating herbs for the nerve and for the brain cells. It's also believed to be capable of increasing intelligence, longevity, and memory. Studies have shown that Mandukaparini or Gotukola has these asiaticoside derivatives that reduce neuronal cell death and also bring down the inflammation. Shankapushpi convolvulus pluricollis is a nerve tonic for improving the memory and cognitive function. A wide range of secondary metabolites, including terpenoids, flavonol glycosides, anthocyanins, and steroids, have been isolated from this herb, and this could be responsible for Shankapushpi's memory enhancing properties. Shankapushpi also calms the nerves by regulating the body's production of stress hormones, including adrenaline and cortisol, thereby lowering the stress response. Brahmi or Bacopa monuri is a nerve tonic. It's also a heart tonic and a rejuvenative herb for nerve and brain cells. It improves the cerebral blood flow. It reduces neuronal cell death and it decreases inflammation. Ashwagandha, Withania somnifera, is a nervine tonic and adaptogen and helps the body to adapt to stress. It's believed to possess antioxidant activity, free radical scavenging activity. It stimulates neurogenesis and it also has an ability to support a healthy immune system. Guduchi or Tinospora is a potent detoxifying herb that also has anti-infective and anti-inflammatory activities. It's a powerful liver tonic. Shilajit, which we use primarily for the type 3 AD, is a very powerful anti-infective, detoxifying, and a metal chelator. Haritaki, which we also use for the type 3, is a potent anti-infective and a detoxifying herb. Pepperly or long pepper, garlic, turmeric, nutmeg, coriander are all potent anti-infective and also stimulate the digestive process. These herbs are administered as tablets, as churnas or tea, as medicated oil in form of thylam for massage, and as nasyas. Nasyas are oil-based herbal formulations for intranasal delivery. So to conclude, based on 20 plus years of lab research, we have now come up with a very comprehensive multimodal strategy to mitigate the memory loss and cognitive decline associated with Alzheimer's disease. In addition, our therapeutic program also improves several aspects of metabolism and offsets the inflammation and stress that underlies the disease. Our program calls for good dietary and eating practices. It calls for good sleeping practices, physical and mental exercise, supplements, neuroceuticals to address the neurons and the brain function, and cognitive ceuticals to enhance the memory aspect. My presentation is supported by a subset of peer-reviewed publications as shown in the slide here. These publications describe a comprehensive strategy to bring down Alzheimer's disease by improving several aspects of metabolism. We all now have an ongoing small sample size IRB approved clinical trial, and the initial results are very encouraging. So once again, I'd like to thank the Stanford group for organizing this conference, and to all the participants